Welcome to The Learning Post, a podcast dedicated to sharing insights and learnings from UK Aid Match. My name is Emma Hayward, and I'm a Performance and Risk Manager for UK Aid Match, as well as your host for this episode. In this episode, we speak to Dorota, Programme Manager at CBM UK, part of CBM Global Disability Inclusion, who've recently completed a 3-year project in rural Rwanda aimed at improving access to quality, inclusive and comprehensive eye health services. Good morning, Dorota, and thank you for joining me.
Good morning, and thank you for giving us the opportunity to talk about our project.
No problem. To start us off, could you tell our listeners a bit about your project in Rwanda and outline how the project design and implementation supported disability inclusion?
Sure. So CBM and Kabgai Eye Unit, who is our partner in this project, have a long-standing relationship with the aim to support equal access to eye health for people in Rwanda. So over the years, CBM has been supporting Kabgai to develop its infrastructure, human resources, also equipment, and that helped Kabgai in becoming what they are now, which is the most productive eye health center in Rwanda. This project took a very similar approach, strengthening public hospitals using experienced Kabgai Eye Unit staff to provide training and mentorship to staff at ophthalmology departments. So CBM as a disability inclusion organization always works to remove barriers that people with disabilities might face, including improving their access to healthcare. So this project also had specific objective, which was to contribute to services at ophthalmology departments being more accessible and inclusive. So we've done it through collaboration with organizations of persons with disabilities by conducting with them accessibility assessments of the facilities at the start of the project. So this was looking at accessibility in different areas, infrastructure, communication, policies, etc. And this followed by specific adaptations made based on recommendations from these assessments. Another part of supporting disability inclusion were activities aimed at developing the hospital staff skills to help them in identification and provision of the support to patients with disabilities. And this through training in disability inclusion, training in inclusive eye health, which were also organized with the support of organizations of persons with disabilities like National Union of Disability Organizations of Rwanda, NUDOR. We also organized sign language training for staff at hospitals to try to remove the barriers that patients with hearing impairments might face, and that in collaboration with Rwanda National Union of Deaf. And the main strategy for reaching people with disabilities with services was done through strengthening of the collaboration between hospitals and primary health centers in their catchment areas, in the areas where they work, as well as community health workers. And of course, again, organizations of persons with disabilities present in the area. So that led to identification of persons with disabilities living in the communities, and we were able to reach them with the information of what services were available for them.
Wonderful. It sounds like partnerships with organisations of people with disabilities are particularly important in successful implementation of inclusion of people with disabilities. We know that for many grant holders, collecting relevant data for people with disabilities is a major challenge in supporting disability inclusion. Could you tell us about how CBM approached disability data collection and management in the Rwanda project, and particularly how you involved those external partners and stakeholders in this?
Luckily for us, the Ministry of Health in Rwanda has been thinking about introduction of Washington Group questions, which are internationally recognized surveys that collect data on disability. This, among others, thanks to advocacy by CBM and other organizations. The public hospitals we were working with were responding positively to the idea of training and introduction of the short set of Washington Group group questions in their system. And CAPGAI unit has been trained in the methodology by CBM previously, so they knew how to do it. Washington group questions, even though they are internationally recognized as the best existing system for collecting data on disability, that is internationally comparable, there are some very specific challenges when introducing it into the health system. It's not easy to use Washington group questions by health professionals because they perceive disability as a medical condition rather than focusing on the barriers that people are facing. And also it is very difficult to seat the authority and allow the patient to assess themselves, to assess the difficulties they are experiencing when doing everyday activities, and based on their assessment categorize a person as having or not having disability as per methodology of Washington group questions. So even though we did first the training in disability inclusion, staff needed to understand why it was important to disaggregate data, basically without knowing how many people with disabilities they were reaching. It was impossible to know who was not being reached and how to change it. And also this training in disability inclusion was aimed to provide them with understanding of other models of disability, social or rights-based model, which perceives disability very differently than a medical model. But still, it's a very long process to shift the perception that disability is created by the barriers that exist in the society rather than a medical conditions. In addition, it's a common challenge that was related to data collection in general. So the digital system used by the hospitals to record statistics have not yet had disability-related category. So it was more work for hospital staff to complete relevant data in the additional register provided by the project. Introducing the collection of data disaggregated by disability into the systems took a long time. So the data started to be collected in the second year of the project. Then there was a need for reviewing how the process has been going, and we decided to go with the refresher training as well.
Yeah, brilliant. Thank you. Even more impressive within that 3-year time frame is one of the major successes of the project is that I think one of the district hospitals that you were working with had actually introduced disability data collection into their systems. Is that correct?
Yes, I think that all participating hospitals started thinking or started introducing disability data disaggregation also in other departments beyond ophthalmology. So that means there is a clear buying into idea that there is a need for disability disaggregated data, and they were telling us that one of the reasons they think they might use this data is to have argument for budget allocation for further improvements in accessibility, because again we focused our efforts on improving accessibility within the ophthalmology departments. So now the hospitals are planning to do the same things that has been done in ophthalmology departments elsewhere, and the data will help them to get the resources. If they will be able to show how many people with disabilities actually are attending the hospital, then that would be easier for them to secure the budget for further improvements.
Yeah, wonderful. I think that's a huge achievement and really good example of the added value actually that the project has created. Finally, Dorota, what would be your top 3 recommendations for other grant holders in supporting and improving disability inclusion within their projects?
So definitely invest in training in disaggregation of data by disability. As we all know, in the absence of data, persons with disabilities will remain invisible, but also it is necessary to train before, as I mentioned, in disability inclusion in general. And then if you can involve in your projects staff with disabilities, there is really no better way to raise awareness and promote disability inclusion than this. But in general, there must be in some way participation of persons with disabilities in the project, and if not through staff, this can be done through collaboration with organizations of persons with disabilities. In our case, they participated in accessibility assessment, in trainings, in monitoring and raising awareness. In general, the accessibility assessments are a great way to start as well, because it will give you the baseline of the situation, and you will know what to do basically to improve inclusion. And then finally, a budget, because you need to budget for those trainings, you need to budget for participation of organizations of persons with disabilities. You need to have a budget for assessment and then for improvements. If possible, it's good to have a flexible budget line for reasonable accommodation, meaning any modifications that you will need to do to make sure that people with different disabilities can participate and access activities and benefits.
Wonderful. Some very clear and practical recommendations there. Thanks for sharing your experiences with us today, Dorota, and congratulations to CBM and partners on the progress made towards disability inclusion in Rwanda.
Thank you for inviting us to talk about this.
Listen out for our next podcast episode in this short disability inclusion series, which will focus on our organisational approaches to disability inclusion at Mannion Daniels. To find out more about UK Aid Match projects, head over to the grants section of the UK Aid Match website at ukaidmatch.org/grants. And don't forget to subscribe to the Learning Post so you don't miss any future episodes. Thanks for listening.